say you find a fracture of the pedicle at C3 on your plain film and you get a CT, you also find a little laminar fracture there too. And they call that, well, see, they missed that on the plain film. Well, that's a contiguous injury, and we expect to see a lot of those when we get in more advanced imaging. Daphner's one in 3. Daphner's a radiologist from Pittsburgh. He's a good guy. He writes a lot of stuff, and he does good work. And what they did is they took as their sample 245 trauma patients with a C-spine fracture. So they already selected those out, who underwent a 6-view plain film and helical CT scanning. They didn't randomize anybody to this. They just said, we pick those that, for whatever reason, the ER doctor said, I want both films and CT. So these are obviously, again, those people who had clinical judgment applied, and they concluded, actually they had a 4-slice scanner, and they said that actually, you know, they found lesions on the CT that they didn't find on the plain film, as you would expect. So 4 is one of these things from the Journal of Trauma. This is from the University of Pennsylvania. Retrospectively looked at C-spine clearance for adult blunt trauma patients with a focus on 640 patients who went a 3-view plain X-ray in addition to head CT scanning. So they must have had something wrong with their head or suspected wrong with their head. And then plain X-rays were anatomically inadequate in 72%. And CT studies of the spine identified lots more than the plain films, but they already said the plain films were inadequate. So then when they come to this conclusion that the sensitivity of plain films is 31%, it's already inflated because you knew the plain film wasn't good enough anyway. So I think these things are being gamed to show you how bad plain films are in these. The one I really like in here is number 5. And while I've sort of poo-pooed the we did it, we like it protocol kinds of things, and that's exactly what this one is, I think it comports with how you could read this literature. So this is Santa Barbara Cottage Hospital. And what they did is they said, if you took a blunt trauma patient and you couldn't clear them clinically, which they meant was altered mental status, distracting injuries, persistent neck pain, they underwent CT scanning of the C-spine with follow-up MRI if the CT was negative but they had a neurologic deficit or if they were comatose and under neuromuscular blockade. And they found everybody by doing that kind of protocol except one patient, and what they didn't find was syringomyelia, a little cystic area in the spinal cord. You're not going to find that on these things. So what they concluded was their protocol was good, and I agree. So this brings up the issue of who needs what kind of filming. And I'll get to more of a survey of that in just a little bit. 6 is spinal cord injury without bony injury. This SAWARA is everybody's nightmare. In the past, it used to mean that you had a neurologic deficit, but you had normal plain films. Then with the advent of CT scanning, people sort of flopped that over into, oh, and you also had a negative CT scan. And the typical injury in these folks is they have a transient subluxation that reduces, so they've now just dinged their spinal cord and they have spinal cord findings, or they had a ligamentous injury and herniated a disc, and it's the disc present on the spinal cord that causes the deficit. And 24% of those had a disc herniation, cord compression, and 6%. I think this is only everybody's nightmare if you don't examine the patient. But I think actually these patients are the, quote, easiest for us to work up because they have a neurologic deficit. We're not going to let any of those people go home or come out of cervical immobilization. I mean, they're going to get advanced imaging, consultation, all that kind of stuff. The biggest nightmare of this SAWARA scenario was those who had transient neurologic deficit in the field. They said, oh, when I was riding in, my arm was numb, and now they're normal. Well, was that because they positioned their arm badly, or was that they dinged their spinal cord, transiently bruised it, and now it's back to normal, but they're going to get that cascade of hemorrhagic necrosis that happens with it. That was always the nightmare, because as you're getting ready to say everything's okay, they're all of a sudden got deficit. But that's not the case with the ones that come in bad. 7, I thought was good, is it one of these conclusions that of course you do. They say CT scanning in all of these cases was the gold standard, so it found everyone. Well, that's the definition of the gold standard. I didn't think that really helped. However, the conclusion was good. The authors feel that the limited evidence supports CT scanning as the initial imaging modality in patients at very high risk. So I think what we need to do, and I'll kind of give you some of my conclusions from a lot of this before we go on to the rest, is separate out the patients into one of several categories. Can you do a good clinical exam on the patient? They're cooperative, they can do strength and motor, and they're reliable at telling you things. That's one category of patient. Then there's plenty of others. They're obtunded from their head injury, alcohol intoxication. They've got everything else busted up, and you've had to give them a lot of pain medicine and maybe neuromuscular blockade, where there's no way you can rely not only now on your clinical exam, but you're never going to rely on it in the short term. Do you think that that person probably doesn't have anything wrong in terms of a C-spine fracture? They have a little bit of symptoms, but nothing to suggest anything bad. You know, most people with a C-spine fracture, no matter what they do, they don't move their neck much. It's rare that the person says, you know, well, it's just kind of, when I kind of go like this, I think it hurts. You know, they're pretty much showing you they don't have a fracture there. Do you think that they will have an abnormal C-spine film as a baseline problem? They're old, they have degenerative disease, they're a rheumatoid where they're going to have subluxation at C1-2, which happens a lot. Other patients with Down syndrome have subluxations at C1-2 as a normal finding. Where you're going to say, oh, wait a minute, there's so much degenerative change here, and there's so many osteophytes, I can't tell if one's fractured or not. If you think that's going to happen, why bother then, again, I think with plain films. And then there's the patients who are clearly severely ill, badly traumatized, bad head injury, everything else bad, where you're just the first stop on their way to the trauma surgeons. And after you get done with them, basically nobody else cares about their neck. So you need to really be sure that you can let people, you know, move their neck to put NG tubes in and take them to the OR and do all their surgeries and stuff. So of course you're going to need advanced imaging on those. I think that's one way to look at this. 10 is a typical one. It's actually a patient from University of Michigan. They went back and looked at how long it took if you just got plain films in fairly sick patients versus just CTing them. And what do you think they find? Oh, the CT is so much faster. If they're on the table for anything, CT saves so much time. Because, you know, in the old days, I don't know how many of you still have to do this. When you want to see C7, you know, you have to go into the x-ray room and stand there and pull on the arms and put on your radiation-proof gown and then look at the film, and then they put their arm over their head, and then they develop that film. And, you know, it takes forever to get really good clearance. If you think that's going to be the case, it's not worth your time. Actually, what they did is they took registry of patients who got both plain spine x-rays and a contrast CT of their chest, abdomen, and pelvis. So these are clearly sick people. And what they found was that if they have a chest CT, a CT of their chest, abdomen, and pelvis, CT their neck. Good conclusion. I like that because they obviously are sick people. Daphner did the same thing, a time study in 11. 12 minutes to get a CT and results in 22 minutes on plain film. I think they're actually fairly fast on plain film. The other thing that you have to do to get plain films on these people is you got to move them to a new table. And now you need all the transport and all their chest tubes hanging out, you know, all that kind of stuff. So I think it's for sure you ought to do that if they are going to get other scans. Let's see here. Oh, so in using the issue of the CT as the gold standard, so what can CT miss? Well, first of all, CT is good at bone. It's very good at bone. However, you realize the way you do a spiral CT is the spiral is spiraling around the head this way, around the neck this way, and then the detector's on the other side. So that's the plane of the X-ray. If you have less slices, and some of these there was a British study, had a one-slice CT scanner. I didn't know they made one-slice CT scanners. There's actually an Australian study, and there was a four-slice CT scanner. That was actually pretty much the standard until, you know, technology took over. But in any event, if your slice doesn't go through the area of the fracture that's oriented in that plane, it has never been imaged. You can't reformat it to find it, okay? So CT as a technique cannot find things in the plane of the CT if it goes in between. So if I have an injury here and I scan here and here, I haven't scanned the injury. That's why bigger slices find more things, but it's also why CT won't be perfect at finding some fractures. And there's a couple of studies in here that have that. CT missed an occasional one that plain film saw. So plain film can sometimes see something you can't see on CT. And then, of course, CT can't see spinal cord, it can't see ligaments, and it can't see discs. Maybe you're going to get prevertebral soft tissue swelling, but that's a judgment in CT, just like it is with plain films. When you look at it, you say, well, I think it's a little more swollen. And actually, if the fracture is posterior or lateral, you may not get prevertebral soft tissue swelling. And if you get prevertebral soft tissue swelling, it can be from soft tissue injury and not something related to the spine. So CT isn't perfect either. The other thing that it can't see is subluxations that have reduced, okay, or subluxations that are still there. Let's say you have one element here and one element here, and you scan it this way. What the computer does is it puts that back together like this, okay? So you will not see sometimes subluxations that are actually there and on the plain film. That's the beauty of MRI. MRI is not dependent upon the patient's position. You know, it doesn't do the same sort of spiraling and that kind of stuff. I don't know that I can even explain how it does it differently, but I know it's different. So that's one thing that's the advantage to MRI. MRI is good at looking at soft tissue edema. It's good at looking at discs. It's great at looking at the cord, and if there's hemorrhage in the cord, hemorrhage around the cord. It's not quite as good at cortical bone, okay, so the outside of the bone, it's not as good as CT. It's excellent at cancellous bone, the center part, the marrow and that kind of stuff. So a lot of times CT will report that there's a squash, the marrow isn't, but they don't see it going through the cortex. And then you get either a plain film or a CT and you'll see it through the cortex. So those are the reasons why some things miss some things and others don't. How about the role of helical CT scanning in assessing pediatric cervical spine if they require a head CT? So now, I haven't brought up the radiation issue yet, but in children, you know, we really do worry about that. They have a lot more time to have the ill effects of radiation take place. It's 200 times the amount of radiation from a neck CT as it is a plain film. And again, it's not only that they have more time to develop whatever radiation does that's bad, but you don't know how many of those they're going to get in the future, kind of stuff. So there is good reason to be parsimonious about thinking about CT in those. And so what they found was that in 16 was that they didn't avoid sedation in these kids. You know, to get a good CT of the neck, at least in the old days with a slow scanner, you might need to sedate kids. So that's another risk going with it. But they took it in kids who needed a head CT already. And I think that, again, is just like adults. Now you're talking high yield, and that's probably a reasonable thing to do. 17 mentions that 200 times the radiation dose. So now the other end of this age spectrum, 18 here, a detection of cervical spine injuries in alert, asymptomatic, geriatric blunt trauma patients who benefits from radiologic imaging. So I don't know how they selected these people. They took 274 hemodynamically stable, alert, oriented blunt trauma patients age 64 or older, mean age 76, who had normal neurologic exam, were not intoxicated, and had no neck pain or tenderness, who underwent both plain X-ray and CT. Well, why did they do that? I mean, they've just described most people who are pretty much normal, but yet they had both. They didn't take those who just had one and discharge them, but for some reason, again, this is where the clinical judgment had to have come in to say, I also need a CT. Did they have such an abnormal plain film or something like that? So they actually found plain films. They said, I think it was 3% was the number of what they found. And one injury was seen on X-rays but not CT scanning. Again, it's an uncommon thing, but it runs through the literature that you'll find. Okay, so CT scanning of the cervical spine in unconscious intubated trauma patient. Every article says the same thing, got to do it. If you're really getting the head CT because they're unconscious or intubated, there is no reason not to do the whole neck. In one of these, they said, just do the upper cervical spine. What, you know, it's more effort to talk to people about getting just the upper cervical spine, and it doesn't save anything. So every one of those show that, and it is not perfect, however, because what are you going to miss? Pseuora, discs, ligament injury, all that kind of stuff. But I think that's not controversial. 22 is the one that said just do the upper part, and I'm sure, yeah, it's a British paper. Always would be. What is the role of MRI in the obtunded unconscious patient? So now if you have somebody who's going to be in an intensive care unit for a long time, say they're intubated on a respirator, they have multi-organ trauma, and they have pins and wires in all their extremities, and there's no way you can really examine them. They have casts and all this kind of stuff. Some people have said, you know what, before you actually take that collar off, knowing that there's such, maybe you ought to do an MRI on all those people. I actually don't think this is really an emergency department issue, because I think if the patients are as ill as I just described, the logistics of getting an MRI on them becomes overwhelming. You know, just all the metal and all the special ventilator tubing you have to have and all that kind of thing. But just to know what people have said, there's some in here who say you do need to do it, you find the occasional one, and most of the others say, the shock trauma from Baltimore and the others said, you know, if the CT was okay, we never really found anything we did anything about. So you can read those if you're interested in it. What they did, though, is they said those who have no motor deficit were the ones that they said were okay to just rely on CT. Well, you know, motor deficit's a tough thing to find, you know, when they have a big cast on one leg and a pelvic fixator and, you know, IVs and casts and all that stuff, to say that it's really normal. And what they meant was that the extremity moved. I mean, it was that crude. But be that as it may, I don't think that's as much an issue for the emergency department. Is magnetic resonance imaging necessary in the patient with a obtunded to just go straight to MRI? And I don't think most of the studies support doing that. You're going to find what you need. And all of those people seem to me they have other logistical issues that are outside of just their head by the time they've gotten that bad. 32, I thought, was actually an excellent one to kind of go over just a little bit. University of Wisconsin, meta-analysis of 5 published studies. Patients who had clinically suspected C-spine injuries or unreliable clinical exam. So this is now what I think is, that's physician judgment. You really think something's going on, or you can't reliably examine them, in whom plain films, with or without CT scanning, showed no abnormalities. And so they looked at doing MRI on those. The pooled sensitivity of the MRI, having an MRI was 97%, specificity 98%. Conclusions, this is the case for MRI. When you really think they have that neurologic deficit and something going on, those are the people to push for. Yeah, I thought 35 was interesting. Single slice CT. How about flexion extension views? How many here used to get flexion extension films? How many do anymore? Yeah, it's always a tough one to think. I can remember getting a lot of these where you know you can miss ligamentous instability on plain film. You can miss it on CT. So with I used to call the workup of the persistently painful neck, this is the person where you come back and you say, hey, good news. All your films and all your studies are normal, and they will not lift their head off the stretcher. That I've always taught. There's something wrong, and you just haven't found it. If they say, I can't lift my head up, don't make them lift their head up, kind of thing. But some people just have persistently painful neck. There were 2 lines of conflicting reasoning on it. One is, let's go and do a flexion extension film and see if maybe they have a ligamentous injury. And the counter to it was, you know, if they have that early on, you're not going to find it because they have spasm. And, you know, the limitation, you only do it until they hurt, and they already hurt. So you wait 3 to 5 days and, you know, have them follow up and then get it then. That was the sort of counter to why we never need to get these in the emergency department. And then do you lift their head and have them do that, or do you allow the technician to do it? I mean, there were protocols that did that that made me just lose sleep at night. Or do you have the patient do it until they're too painful? And what you found when you let the patient do it, you never find anything because the patient doesn't move it when it hurts. And then if you had the technicians do it, they kind of stopped on everything. So most of the literature said get it later on. Now that MRI can find the ligamentous injury, I think most people have said there's probably almost no place for it. I know there probably is a place way down the road from the emergency department. A neuroradiologist who just wrote the chapter in our Neurologic Emergencies textbook on imaging, excellent guy. And what he says is, you know, yeah, okay, so now you see a ligament on the MRI. That doesn't tell you if anything's moved. The surgeon needs to know if they need to go stabilize them, so they need to go and do a flexion extension film to see if something moves. Well, that's surgical planning. That's way outside of the emergency department. But I don't think there's any reason to do flexion extension views anymore. There probably wasn't an initial evaluation anyway, and now that if you can get an MRI. So that might be the other issue, is when might you get this, is that people talk about MRI is the test of choice as if you can always do an MRI on somebody. You know, that they don't have metal, that they don't have a pacemaker, all kinds of things, you know, metal shavings in their eye, all that kind of stuff. You know, how many of you here have to fill out the request for MRIs? Sometimes. I mean, there's stuff on there, I don't know, ours is like 2 pages long. And then if you actually have a pacemaker, finding out which of the 2 brands and serial numbers are not okay for it and all the others are. And if somebody had, you know, a lot of laparoscopic stuff and even open surgery has the stapler that they use to, you know, anastomose the bowel and do all kinds of other things. Well, that's metal. How long after that can you have an MRI? I think most people say like 6 months. But that means the patient has to know how they got anastomosed in the operating room. You know, there's no way. And you can even read the operative report, and it says, you know, it uses the, you know, ortho novum GI stapler. And you have no idea what that means. So I think it gets very complicated for some people, and that's where you might have to rely on CT and then flexion extension. Last one, who gets sued for not doing C-spine imaging? This is one of these opinion papers. There's actually a typo in it. They said the average award was $2.9 billion. 2.9 million, still a big number on here if you actually read the abstract. Maybe that's just, you know, 10 years from now, that'll be where that is. But this is a bunch of people who just said they looked at a bunch of medical malpractice cases, and several themes were there. One is they got inadequate films, or they didn't know enough to get advanced imaging when there was an abnormality. So I think this is sort of hindsight and picking apart what's wrong. So I think my take on the whole thing, to kind of bring things back to sort of clinical judgment, is that I don't think we should have knee-jerk CT of the neck for everybody, okay? I think we need to use it selectively, and in those people where you think you're going to find something, where you know you're not going to be able to get a clinical exam that clears the C-spine, if they have any neurologic abnormality, if they're seriously ill, if you're going to do a head CT because they're obtunded now, not just because, you know, they were playing hockey and they were disoriented for a few minutes after they hit their head and their neck is fine. I don't think the old every time you do a head CT, you do a neck CT is quite right. If you think they're going to have an abnormal plain film because they're very old, or they have lots of spine disease, or they say they've had a fusion or some sort of surgery, those are the people you reserve it for. I think we haven't really talked about who doesn't need anything. That's another whole talk. They don't need any imaging. But of those where you think, well, let me get something, I think if you get good, adequate plain films and you get a good, adequate clinical exam, it's rare that you miss something, because then what you always do is you have the exam after the film. You know, get them up, move them around, and see how they're doing. So I don't think we have to go to that exclusively. I know some people disagree with that, but I think they're sort of reading the literature with the caveats that I mentioned. Comments, questions, disagreements? Yeah?
What's the urgency for getting an MRI when you suspect Sawara? Because it always happens at 1 o'clock in the morning. We don't have MRI.
Right. So the question is, what's the urgency for getting MRI if you suspect Sawara? If you ask me scientifically, none. You know, now they have a deficit, and what's going to happen to their deficit over time? Gets worse. And doctor, you didn't do anything during that time, did you? You know, in the past, steroids. Give them steroids. I knew you were going to get to the steroid issue. The steroid issue has, I think, been pretty much put to rest. Even ATLS. I mean, ATLS, the last refuge of the intellectually destitute, has put it to rest. I mean, maybe that's wrong now. When I read that, I thought, oh my God, maybe we should give them. You know, I usually have that point of view. I think somebody needs to know about them. I mean, I don't think you should say, well, you've got a spinal cord injury, I'll get hold of the neurosurgeon 8 o'clock tomorrow morning. Where I am, I can't get it at 2 o'clock in the morning. You know, so if I suspect it, I have to ship them. But if you can get it, but not now, and you're not going to ship them, then I think as long as everybody knows what's going on and that kind of stuff. And you've talked about the steroid injury. And then are they going to go to the operating room for other things, all that kind of stuff? I mean, I don't scientifically see a reason to know it now versus later. But they need imaging of their entire spine and all that kind of stuff. These are people that are going to take millions of dollars of care. And so I don't mind, you know, cranking up the system and saying, get your ass in here and let's figure out what's going on. I think the hardest judgment in the world is this sort of stinger. The kid's playing football, hits head on head, says, oh, I had this neck pain and I had this sort of tingling in my arms. I'm sure it was just my shoulder, you know, or something like that. And now you think, ooh, do they actually have a cervical, unstable cervical spine? What's good enough for them? And I think, you know, it depends on judgment, but those are the people that I think you crank up the MRI for, because that's what you're looking for there. What else? Any other comments, questions?